So without further ado, allow me to introduce today's speaker, Dr. Matthew Poffenroth. Dr. Poffenroth is a member of the American Kidney Fund Board of Trustees and serves as co-chair of the Kidney Disease Prevention, Education, and Outreach Committee. He also serves on the Medical Advisory Committee. Dr. Poffenroth received his medical degree from the Indiana University School of Medicine in 1994 and completed his internship and residency in internal medicine at York Hospital in York, Pennsylvania in 1999. He was the founder and president of a 40-physician hospitalist group in Montgomery County, Maryland from 2003 to 2007, during which time he also received his MBA from Johns Hopkins University. In 2000, Dr. Poffenroth joined Suburban Hospital Health System in Bethesda, Maryland, as president of Premier Physician Group. In 2009, when Suburban Hospital was acquired by Johns Hopkins Health System, Dr. Poffenroth joined Johns Hopkins Community Physicians as regional medical director. He served as chief of medical specialties and director of clinical integration for JHCP and medical director for the Johns Hopkins Medical Alliance for Patients, an accountable care organization. Currently, he serves as chief medical officer for the Signature Partners Network at Inova Health System. Dr. Poffenroth's career has focused on leading and aligning physicians toward a common goal of providing high-quality care with an integrated delivery system. As a primary care physician, one of his primary goals has been to help patients prevent and manage the chronic diseases that can lead to kidney failure, such as diabetes, hypertension, and cardiovascular disease. Thank you, Dr. Poffenroth, for joining us.
Thanks very much, Mike, and thank you to all of those at the American Kidney Fund for giving me this opportunity to speak today. I think this is to commemorate February is the National Heart Month, and in March it's actually going to be Kidney Month. So it's a good opportunity to speak about how heart disease and kidney disease are related. As Mike mentioned, I'm a primary care physician. I'm an internist, and still, even though I've got a large administrative role, I still see patients, and really the foundation of primary care is preventing disease, because if we can prevent disease, then we don't have to be faced with the challenges of actually trying to treat disease and manage disease. So to the extent that we can prevent these diseases, we're all better off. So today what I'm going to do is I'll take us through a discussion where I'll touch on sort of the incidence of kidney disease, and then we'll get into some of the common risk factors for both kidney disease and heart disease, and then discuss how one of those, either kidney disease or heart disease, can actually lead to the other and can complicate the other. And then finally, we'll get into a little bit about just how we can prevent and manage kidney disease and heart disease, and what some of the common complications are for patients that suffer from those. What you're going to see through this presentation is that kidney disease and heart disease are incredibly prevalent and are very highly interrelated, and so it's important to understand both of these. So with that, we can go to the next slide. So here's just some background on chronic kidney disease. So it's a major public health issue, one that's often not thought about. We always, tend to think about heart disease being common and cancer being common, diabetes being common. Quite frankly, the reason those diseases are often thought about amongst the general population is there's a huge amount of public resources that are dedicated to awareness, to nonprofit charitable organizations that are trying to raise funds for research and treatment. You think of breast cancer, for example. Breast cancer is, Breast Cancer Month is October, and anybody that watches NFL football will all of a sudden see in the month of October, every football player has something pink that they're wearing right during the games, right? That's an incredible marketing campaign for breast cancer awareness. Chronic kidney disease, unfortunately, does not receive the same degree of public awareness campaigning. The American Kidney Fund is, one of very few organizations that are focused on on helping patients with kidney disease and try to build up that public awareness. But you know, again, we just don't have the resources that some of these other diseases have. That said, though, you know, the point of this slide is to really show you just how prevalent it is. So we know that, you know, at least 26 million Americans are affected with some degree of chronic kidney disease, and there is a variation in severity of that. But that relates to, you know, over 10% of the population, right? So it's about 1 in 10 or maybe even 1 in 9 adults that have some degree of chronic kidney disease, and that's right on par with breast cancer, for example. It's also an incredibly costly disease, right? So 28% of the Medicare budget is spent on treatment of chronic kidney disease. That's a huge amount, right? So you think of, you know, Medicare is spending for just our general wellness visits, for, I mean, all the health care for patients, for everybody over age 65, plus those with chronic kidney disease, end-stage renal disease, who are on dialysis. That most of that rolls up under Medicare, and you think of, you know, that almost a third of the entire Medicare spend is on treating and managing chronic kidney disease. That's just an incredible thing to think about. So that's $42 billion in 2013, and so again, you start thinking about all the, you know, efforts around to reform healthcare and lower our overall costs and improve quality, and you know, if we focus on this one disease alone, there's a big opportunity here. Kidney disease then, you know, increases our overall risk for dying from anything, from cardiovascular disease, from end-stage renal disease or kidney failure, as well as other adverse outcomes as well. Just generally a poor quality of life for those patients who are suffering late-stage kidney disease. We know there's a 6-fold increase in dying if you have both diabetes and chronic kidney disease. And we also know that kidney disease disproportionately affects African Americans and Hispanics, so there's a social component to this as well. Next slide. So here's some of the risk factors that we'll see for chronic kidney disease, and the next slide then I'll show you is for heart disease. But some of these we can change. They're sort of in our control, and some of these we can't really change. So on the changeable side, I include here diabetes and hypertension. So those are the two most common causes of chronic kidney disease, is long-standing poorly controlled type diabetes or long-standing poorly controlled hypertension. Now we consider those as sort of changeable risk factors, because diabetes and hypertension, although there's certainly a genetic component to it, and there's many people with those diseases that it's completely out of their control, that they acquire those, and so in that case it's really not changeable. But the changeable component of that is those are largely diseases of lifestyle as well. So of obesity, high salt intake, smoking, inactivity, all of that type of lifestyle behavior can lead to the development of diabetes and hypertension, which in turn leads to chronic kidney disease. The second thing why these are a changeable or modifiable risk factor is because for patients that do have diabetes or hypertension, to the extent that we're able to control those, you can prevent the development of chronic kidney disease, right? So well-controlled diabetes, well-controlled hypertension in general is not going to really raise your risk that significantly for chronic kidney disease. But we know that, you know, there's huge numbers of people that have poorly controlled diabetes and hypertension, either because they don't know they have it, or they're not taking their medications the way prescribed or whatnot. Some of the other modifiable risk factors here, so if frequent medication use for over-the-counter pain medications, the abbreviation there is NSAID, which I won't get into, but these are things like ibuprofen, aspirin, Aleve, at high doses, and for long-term use, those can be toxic to the kidneys. Smoking, of course, is another modifiable risk factor that can lead to kidney disease. Things that we can't do anything about, obviously, is a family history. So if you have a genetic predisposition, or if you're over age 60, that's a risk factor. And then, as I mentioned, whether if you're African American or Hispanic, those are independent risk factors for kidney disease. Next slide. So now we look at this for cardiovascular disease, and you're going to see a lot of similarities here. So again, the modifiable risk factors, diabetes and hypertension, just like for kidney disease, are the two most common chronic diseases that lead to heart disease. Smoking, same thing, and then again, the obesity and elevated cholesterol. Chronic kidney disease is a risk factor in and of itself for heart disease. So to the extent that you can prevent yourself from developing chronic kidney disease, you can help prevent your risk for developing heart disease. And then the non-changeable risk factors, same things, right? So family history, being of an older age. And for heart disease, we see more of a higher risk in men versus women, not as much of whether you're Hispanic or African American plays an influence in this. Next slide, please. So now we're going to start showing some data, and I'll explain the slides here, but some data that shows how if you have one disease, if you have kidney disease, how does that increase your risk for heart disease and vice versa? And this is some interesting numbers to look at, and just to try to get your head wrapped around how common this is. This data that I'm going to be showing, this comes from studies that are done on the Medicare population by looking at the claims, or essentially the bills that the government is spending. So one of the kind of fascinating things that we can do when we're trying to do research on chronic diseases and how prevalent they are and what outcomes are is we can look at what Medicare is spending. So every time any patient who's on Medicare sees a doctor, gets a lab test, goes to the hospital, has a test or procedure, all of those obviously generate a bill which goes to the government, Medicare, and that then pays either the hospital or the doctor or the lab or whatever. Well, all of those bills, those claims, are maintained in a huge database by the government, by Medicare. And so we can look into that. So we can see exactly how much Medicare has spent on treating kidney disease over a period of time. And when you look at that then against the entire population, you can start doing some interesting studies just to see that these sort of prevalence things. So this slide here is showing that if you have heart disease, what is your risk then of also having kidney disease? So this is for everybody with heart disease. How many of them also have kidney disease? The first bar is coronary artery disease. So coronary artery disease is the blockages of the arteries that go to the heart that lead to heart attack. So for all Medicare patients, essentially, that have coronary artery disease, 23% of them, so a quarter of them, also have kidney disease. For all patients that have had a heart attack, right, so this is like more severe coronary artery disease, a third of them have chronic kidney disease. And then the third kind of main cardiac disorder here is congestive heart failure. So that's when patients' heart starts to fail as they get older, and many of you, either yourselves or family members or friends or whatnot, will know somebody that has congestive heart failure. That's when your exercise stamina decreases. You can get fluid that can build up on the lungs or the legs and whatnot. Various things can lead to congestive heart failure, but the point of this slide is that for patients with congestive heart failure, almost half of them have some degree of chronic kidney disease. That's an important relationship, because as the heart fails and isn't pumping blood as effectively as a normal heart, the kidneys are one of the first organs that suffer the consequence of that, right? So you can imagine if your kidneys aren't getting effective blood delivered to them from the heart, that can start affecting the kidneys. The next slide then, please. So this turns it around. So this is of patients with kidney disease, how many also have heart disease. So just a different way of looking at it, but with the same point here. And there's a bunch of abbreviations here. I'll go through a few of them. But again, the point is to see the difference between the blue bar and the yellow bar. So for all of these different conditions across the bottom, CVD is cardiovascular disease, or pardon me, cerebral vascular disease. So this is people that have had a stroke, which is in the category of cardiovascular disease. ASHG is atherosclerotic heart disease, which is another word for coronary artery disease, which again is blockage of the arteries. AMI is acute myocardial infarction and otherwise a heart attack. CHF is congestive heart failure. And then the difference between the blue bar and the yellow bar is blue bars are patients that have kidney disease. yellow bars are those without kidney disease. So you can see, for example, the first two bars there under cerebral vascular disease. So that anybody that has had a stroke, you'll see, pardon me, anybody with a stroke, you'll see 65 and almost 70% of them have some degree of chronic kidney disease. And I'm sorry, I misstated that. Let me rephrase that. This is a little bit of a complex slide, and I just want to make sure I get it straight. It's the other way around. So patients with chronic kidney disease, 65 to 70% of them are at risk for having a stroke. Whereas if you don't have chronic kidney disease, your risk drops down significantly. And you can see that that kind of carries across the board there for all these various cardiac diseases, right? Again, the point being, if you've got kidney disease, you're at much higher risk for having heart disease, and vice versa. Next slide. This is, again, this now is looking at for patients who have chronic kidney disease. As your chronic kidney disease gets worse, your risk for developing, in this case, congestive heart failure gets worse, right? So it's, again, showing the relationship between the two. So there's 3 bars here, blue, yellow, and orange. Those are just different bars saying that you have different types of congestive heart failure, okay? But the point here is that it doesn't matter what the different types are, they're all sort of heart failure. So if you just look at the groupings of 3, so if you have no chronic kidney disease, Medicare patient again, and this pertains to the younger population as well, it's just we're using Medicare data. But if you don't have Medicare, if you're a Medicare patient with no chronic kidney disease, you essentially got between a 1.2 and 3.2% chance of having heart failure, some type of heart failure. And then as you develop kidney disease and that kidney disease gets worse, so from stage 1 to stage 3 to stage 5, in stage 5, the way we classify chronic kidney disease is when you're at stage 5, you're on dialysis, so that doesn't get any worse than that. But you'll see that as your chronic kidney disease progresses, your risk of developing congestive heart failure increases as well, okay? So that's, again, just showing the relationship between the two. Next slide. This now shows your risk of dying. So again, Medicare data, right? This is essentially almost the entire Medicare population that we're really looking. It's not, but it's a sampling of the entire Medicare population. And the bars here show what is your risk of dying over the course of 2 years, right? And the top bar there, which is blue, is if you don't have chronic kidney disease or congestive heart failure, but you're a Medicare patient, and you can see, and this is, you know, anybody over age 65, so it's all comers over 65 with Medicare. You'll see that by and large, your chances of surviving for 2 years are pretty good, right? The bar barely dips down. The yellow bar then is if you have chronic kidney disease alone, but no heart disease, well, now your risk of dying increases a little bit. So you can see that survival, the bar shows whether you survive for 2 years is a little bit lower. The orange line is if you have heart failure but no chronic kidney disease. So it's a little bit worse to have heart failure than kidney disease, right, as far as your ability to, or your risk of dying. But then what happens with that last bar, and that's if you have both kidney disease and heart failure, now your risk of dying within 2 years increases fairly significantly. So again, just showing how these two diseases relate to each other. Next slide. This is more mortality data or survival data. Again, each graph was over a period of 2 years. Now what we're showing is if you have heart disease, as your kidney disease progresses, what does that do to your chance of surviving? And if you just look at the end of the graph on the left there, so the graph on the left, this is for atherosclerotic heart disease, ASHD. So for all patients with coronary disease, blockages in the arteries, those blue line, the top line there is how you're going to survive over your survivability over 2 years if you don't have any chronic kidney disease. And then as the bars move down, that's as your kidney disease progresses. So that's basically just showing that as you develop chronic kidney disease and as it progresses, your chance of surviving decreases to the point where if you have, end-stage kidney disease and heart disease, your chance of surviving for 2 years is only 60%, right? That's phenomenal, right? That's an incredibly a powerful slide, I think. The next graph over to the right then is the same thing with AMI, which is a heart attack, acute myocardial infarction. So in general, if you're a Medicare patient and you have a heart attack, you'll see within the first month that most people, if you're going to die from a heart attack, you die right when it happens, right, or within the first week or two afterwards. If you survive that first month, you can see the slope of that curve really flattens out. But the point here again is as you develop kidney disease and as your kidney disease gets worse, your chance of surviving a heart attack decreases significantly. Again, to the point where if you are a dialysis patient, stage 5 kidney disease, and you have a heart attack, you've got basically a 50-50 chance of surviving that, right? So it's incredibly important. Next slide. So how exactly does chronic kidney disease lead to congestive heart failure? Well, there's several different things here. So one of the key things is when you have chronic kidney disease, you develop fluid overload, your blood pressure is higher, it's more difficult to control. That leads to an additional strain on the heart, which can lead to congestive heart failure. This next bullet point here, this is science. It doesn't really mean much to anybody unless you're a researcher or a scientist, but it's basically saying that we know that patients with kidney disease, that the cells that line your blood vessels, they just don't function properly, and they can become inflamed, and that can start leading to blockages, which can lead to congestive heart failure. The other thing is that with chronic kidney disease that you have more of a risk of developing abnormal cholesterol levels, so your bad cholesterol, quote unquote, gets worse, and that can lead to heart disease. We also know that chronic kidney disease can lead to some abnormalities in various electrolytes and salts and minerals in your body, phosphate levels, calcium levels, vitamin D levels. They can be all out of whack when you have kidney disease, and then when those become abnormal, that can actually lead to heart disease as well. So if you have elevated phosphate, elevated calcium levels, that can lead to hardening of the arteries, which can lead to heart disease. Next slide. So preventing chronic kidney disease and cardiovascular disease. So kind of back to my initial point here, it's the old adage, an ounce of prevention is worth a pound of cure. Kidney disease, once it progresses to end stage, to stage 5, you've got 2 treatment options. It's dialysis, which is replacing your kidneys with a machine, or it's transplant, right, replacing your kidneys with somebody else's kidney. There's no medicine that's going to treat it or reverse it. So the goal here is, even for those with chronic kidney disease, to manage it and prevent it from getting to end stage. So same thing with heart disease, right? Once you start having heart attacks and your heart starts failing, there's more you can do with medications to manage heart disease, quite frankly, than there is kidney disease. But again, when you get to end-stage heart disease and end-stage heart failure, you're looking at an incredibly shortened lifespan, and even things like heart transplant and certainly other surgeries, right, bypass surgery and whatnot. So anything we can do to prevent them is that's the way to go. And since they have the same risk factors, prevention is similar to those. So diet and exercise, maintaining a healthy weight, not smoking, controlling diabetes, controlling blood pressure, controlling cholesterol. It's the same for all of us. Avoiding those, prolonged exposure to medications which can be toxic to the kidneys. As I mentioned, the ibuprofen, the Aleve, aspirins. If you have low vitamin D, there's some data out there that actually shows supplementing your vitamin D with a daily supplement can potentially help prevent some of this. We, especially in the wintertime in this hemisphere, we're not getting a lot of sun exposure. Sun is what really our bodies really create our own vitamin D by being exposed to the sun. So if you're indoors, not in the sun, your vitamin D levels will go down, and so that's something that a lot of primary care physicians will check on a regular basis when you go in to see them, is what your vitamin D levels are. And then of course having a regular checkup with your primary care physician. So especially as you're aging and you're getting into your 40s, 50s, 60s, it's really important to get into to have that annual physical exam, because the symptoms of high blood pressure and diabetes and kidney disease, you don't have symptoms until they start to progress to a point where where it's too late to really prevent it, right? So getting in and getting those checked and screened is important. Next slide. So diet and exercise is, again, absolutely key here. And so these are just a slide. This is just a slide that shows what the American Heart Association recommendations are for diet and exercise. You may have heard of these, but in general, the recommendation is to try to get 30 minutes of moderate intensity activity at least 5 days a week, or 150 minutes a week. And moderate intensity is a vigorous walk, right? So 30 minutes, if you can go walk 1.5 miles in 30 minutes, or do some biking or swimming or whatnot, that's moderate intensity. Just kind of taking the dog for a walk and stopping at every bush, for half an hour and you barely get to the end of the block, that's not really moderate intensity. And I'll tell you, as a physician, I have patients say, oh yeah, I get all sorts of exercise, I've got a dog, and that's what they do, right? They walk about a block a day. Or 25 minutes of vigorous aerobic activity 3 days per week. So this is going for runs, is doing more vigorous activity. And then also, in addition to the cardiovascular exercise, the recommendations are at least twice a week to get some muscle strengthening activities. So some weights, some other types of whether it's even just like calisthenic type things like push-ups and sit-ups and whatnot. You don't need to get a gym membership to do this, right? You can do it even with stuff, in your home. And then if you have high blood pressure, high cholesterol, then the recommendations are to a little bit higher than that. So the recommendations are, if you have high blood pressure, then it's really 40 minutes per week, 3 to 4 times, 40 minutes per day, 3 to 4 days a week of the moderate to vigorous intensity. Next slide. So diabetes, right? Again, this is an incredibly prevalent disease which, when poorly controlled or undiagnosed, is a major risk factor for kidney disease and heart disease. We know that there's, 29 million people with diabetes in the United States, 89 million people, right? 1 in 3 that have pre-diabetes, which means that their blood sugars are already abnormally high, not in the diabetic range, but are going to become diabetic if they don't do something about it. And many of these 89 million with prediabetes, this can be reversed through lifestyle changes. I've had patients that have been on high doses of insulin and other oral medications to manage their diabetes. They're overweight, they're inactive, and they get onto a vigorous exercise program. They really watch their diet. They lose 50 pounds. All of a sudden, they're off all medications. They're essentially not diabetic anymore. So that's just key. Now, and that's not everybody though, right? So when you do have diabetes, again, the diet and exercise is important, but if it can't be controlled with diet and exercise alone, then making sure that you're on the right medications, that you're visiting your doctor and keeping it under control, controlling your cholesterol, that's all important. Next slide. This slide here is just, again, another sort of visual slide showing how diabetes, chronic kidney disease, and cardiovascular disease, how they're related. The size of the circle is sort of the prevalence, right? So, cardiovascular disease has the biggest circle because if you take the entire population in the U.S., more people have heart disease than they do diabetes or kidney disease. Diabetes and kidney disease are both about the same, right? So diabetes and kidney disease, about 30 million people each. Cardiovascular disease is about twice that. But then that middle box there, that red, this is what we call a Venn diagram. What that shows is that there's that percentage then that have all 3 of these. And it's red for a purpose, because when you have diabetes, kidney disease, and heart disease, that's when your mortality is significantly increased. So next slide. Hypertension, so similar to diabetes, hypertension is incredibly prevalent. And same sort of thing. This is a lifestyle-related disease, right? So diet and exercise, low sodium, smoking cessation, and then medications, right? So I'd say less so than diabetes can blood pressure be controlled with diet and exercise alone. Medications are often necessary. But again, people don't have symptoms from heart disease, or from hypertension, unless it's so severe that they're having headaches or changes in vision or strokes or whatnot. But there's millions of people out there walking around with elevated blood pressure and they don't even know it, or they know it but they don't feel it, and so they don't think to take their medications. They're non-compliant, and they think, oh, I forgot to take my pill today, no big deal, I'll take it tomorrow. Well, every day you go with poorly controlled high blood pressure increases your risk slightly for developing other diseases, right? And so it's, again, if you have a diagnosis of hypertension, I cannot stress enough how important it is to really modify those, parts of your lifestyle which you can, have regular visits with your physician, and be compliant with your medications. Medication compliance for high blood pressure and diabetes, if we had a perfect compliance across the United States for those two diseases, we would decrease our incidence of kidney disease and heart disease significantly. There would be no need for Obamacare to lower cost of care in this country. And I'm editorializing here a bit on my, so don't take that the wrong way. But the point is that so much of what we spend in healthcare in this country to manage these diseases and the complications from these diseases could be better managed with much better outcomes and much better quality of life by simply preventing and controlling them through, again, diet, exercise, and compliance with your medications. Next page, next slide. Cholesterol. So cholesterol is also part of the mix here. These are just the recommendations for patients that have chronic kidney disease, whether or not you should be on medications. Now, we used to think that we'd have to, if you had kidney disease, we would measure your cholesterol level, and if elevated, above a certain level, then we'd put you on a cholesterol-lowering medication. These things called statins. So you see the commercial for them, the Lipitor and other cholesterol-lowering medications. What we now know, though, is that these medications actually have a benefit for patients with kidney disease, even if you don't have an elevated cholesterol level, right? So really getting the cholesterol level incredibly low. So any adult who's over age 50 and has chronic kidney disease, it's recommended that you're on a statin medication, something like Lipitor or Crestor. For adults less than 50 who have kidney disease and another disease like heart disease or diabetes, same thing, then the recommendation is to be on a statin regardless of what your cholesterol level is. And then certainly if you have, the other thing is that if you have kidney disease and you're on dialysis, if you have end-stage kidney disease, then it's almost paradoxical, but in that case, putting those patients on these medications is actually a higher risk. So we don't treat patients who are on dialysis with cholesterol-lowering medications. But again, the point here is if you're listening to this and you know you've got kidney disease and you're over 50 and you're not on a statin medication, you should go talk to your doctor about that. Next slide. And this may be my last slide. So this is how, what are the various complications that patients suffer when they have kidney disease that can impact your heart disease, right? So for patients that have both, what complications come from kidney disease that impact your heart disease? One of these is anemia or low blood count. So your kidneys, normal healthy kidneys, produce a hormone which tells our bone marrow to make red blood cells. As the kidney disease progresses and as kidneys fail, they stop producing that hormone and people can become anemic. Their blood counts can become low. 20 years ago, a pharmaceutical company was able to identify this hormone and essentially since make it. And now everybody on dialysis, most people get shots of this hormone. It keeps their blood counts up. It's a lifesaver for people. Prior to that, people used to have to get transfusions on a regular basis. But anemia, having a low blood count, can put an additional strain on your heart if you have heart disease. So that's one of the complications. The other thing I mentioned earlier was high blood pressure. Chronic kidney disease in and of itself leads to high blood pressure because of salt retention and fluid retention. That puts an additional strain on the heart and can lead to heart failure. And then I mentioned this as well, calcium and phosphorus levels. So the kidney also produces a hormone which helps guide how our bodies handle calcium and metabolize calcium. So as the kidneys become diseased, the calcium and phosphorus levels become out of control, and those can lead to that can lead to hardening of the arteries as well. And next slide, or is that the end? Nope. So this is the last slide. So just some kind of key takeaway messages, and I think you've probably picked up on this by now. But it's, that chronic kidney disease, cardiovascular disease, diabetes, and hypertension, they're all very common and they're all related. Lifestyle, the smoking, exercise, diet, this is the biggest risk factor for all of these, and it's hence the main treatment, right? Prevention is absolutely key, and then routine visits with your primary care physician to screen for these diseases, and then if you have them, to help you manage those diseases to the extent that you can. And that's the end of my presentation, so I'll be able to answer some questions if Mike can direct them to me.
Great. Thank you very much, Matt, for leading such an excellent webinar. At this time, I'll ask you to answer a few questions we've received. The first one is, you mentioned it's important to avoid long-term use of pain medicines, including aspirin, but many people are told to take aspirin for management of heart health. What is the right thing to do?
Yeah, so that's an excellent question. So an aspirin works a little bit differently than some of these other pain medications, and I'm keeping Tylenol completely separately, but aspirin works a little bit differently than the ibuprofens and Aleve. Aspirin is also a bit of a blood thinner, and so low-dose aspirin, either a baby aspirin, rarely a full-strength aspirin, is a recommended treatment for patients who have either had a heart attack or a stroke. So that's secondary prevention, meaning you've already got the disease. We don't want you to have another, or you have known heart disease. We don't want you to have a heart attack. So all those patients, the recommendation is to be on a baby aspirin a day, which is a bit of a blood thinner and can help prevent a heart attack or a stroke. Primary prevention, meaning that you've not had the disease yet, so you haven't had a heart attack yet or a stroke yet. Depending on your risk factors and whatnot, your doctor may also recommend for you to be on an aspirin a day. And again, that's predominantly to avoid the risk of stroke and heart attack. Low-dose aspirin daily, the biggest risk of that, quite frankly, is an upset stomach and maybe even a stomach ulcer. When I'm talking about these drugs being toxic to the kidneys, it's high dose, right? So it's somebody who has, arthritis, right, or a bad back, and they're taking not 1 or 2 Aleve per day, but they're taking 8 or 10 or 12 or 16. And for most of us, we think, well, who would take 16 Aleve a day, day after day, for more than, you'd be amazed. So people, if they get pain relief, they'll do it, right? Tylenol is not toxic to the kidneys, but Tylenol is actually toxic to the liver. It's a separate thing. These medications also, so the high dose anti-inflammatory drugs can also be a toxic to the heart as well. But again, we're talking about very elevated doses every day for months, right? So not a lot of us are doing that, I hope.
Great, thank you. We have another question regarding the difference between good cholesterol and bad cholesterol. Which one's more important to look out for, and can you raise your good cholesterol and lower your bad cholesterol, and if so, how would one do that?
So sure, and so the research on this is changing as well. So the good cholesterol is what we call HDL, high density lipoproteins, and the quote-unquote bad cholesterol is LDL, low density lipoproteins. We used to think, that HDL, more HDL is good, and less LDL is bad. So more of the good is good, less of the bad is good as well. Definitely with the LDL, the bad cholesterol, lowering that for patients with heart disease, diabetes, kidney disease is beneficial. The studies have absolutely shown that. What's changed with that thinking, though, is, I mentioned this earlier, is that if you have the disease, if you already have kidney disease, or if you already have heart disease and diabetes, and you have high risk for developing, heart attacks and whatnot, then even if you have a relatively low bad cholesterol, the medications are still beneficial. Now, the good cholesterol, we also used to think that raising the good cholesterol was also protective for the heart, and there's some recent studies now that show that may or may not actually be the case. So the jury's still kind of out on it. But the fact of the matter is there's no medicine out there that does a very good job at raising HDL. The statins are excellent at lowering the LDL. They're incredibly powerful. But raising HDL, the good cholesterol, that's more of a lifestyle thing, and it's really exercise, right? So exercise can help your body drive up your HDL a little bit. Diet plays a factor too, right? So diet has a high fat, high cholesterol diet. A lot of fried foods, a lot of high fat foods, the butters, the creams, the oils, and all that can lead to elevated bad cholesterol. But we know that actually genetics is more of a driver than diet, actually, quite frankly. So.
Thank you very much. I must say you're getting a lot of questions, so thank you for taking the time to do this because they are rolling in. A question on vitamin D. What exactly is the mechanism of vitamin D and how it affects heart health? And are there different recommendations for the amount of vitamin D someone should have depending on their stage of kidney disease? Is there any difference for someone that's on dialysis versus someone that's had a transplant or early stages of CKD?
Yeah, so let me try. So there's a bunch of questions there all in one. So as far as the mechanism for vitamin D and how it impacts, kidney disease and vice versa. So vitamin and heart disease. So vitamin D is involved in our body's normal metabolism of calcium and phosphorus, and it's all hormonally controlled through hormones that release from your kidneys and hormones released from your brain. It's an incredibly complex pathway. It's one of these things that when you're a medical student, you spend, the night before the test, you spend hours and hours reviewing this and memorizing it. You take the test and then you forget half of it because it's a complex type of pathway. But the point is that low vitamin D levels can impact your calcium and phosphorus levels when you have kidney disease. And then again, if the low calcium or elevated calcium can actually have either. And the elevated phosphorus, it can then lead to secondary problems with your heart vessels, with some even like getting calcium deposits in your skin and joints or whatnot. So that's how vitamin D, we know, directly is related to kidney disease. Now, there is the other interesting thing, though, is there's been a bunch of studies out there that show a trend that low vitamin D can be associated with a bunch of things. Can be associated with diabetes. There's been studies that show that it's associated with a higher risk of heart disease, a higher risk of kidney disease. So it's not that the kidney disease comes first, but it's the low vitamin D might come first, even some cancers. Now, these studies are not very. It's a trend that has been noted, and there's some suspicions around it. Depending on the study and the person you speak to, they believe this is real. Some believe it's not real. This all started kind of coming out in the research about 5 or 6 or 7 years ago, and then all of a sudden, everybody was told to test for vitamin D and replace vitamin D. Now the research is not quite as, there's just still questions about it. So I think, it's not a magic bullet by any stretch of the imagination. I think having normal vitamin D levels is a good thing. There's only a few things in your diet that have vitamin D in it. So like salmon, for example, some of the oily nuts will have vitamin D, but by and large, vitamin D is our body's, as I mentioned, it's sun exposure, which creates, triggers your body to produce vitamin D. And I think, if you want to get your levels tested by your doc, and then he can guide you on how much, or she can guide you on how much to take, that's fine. Otherwise, there's no harm whatsoever to take a regular supplement, whether it's 400 units or 800 units of vitamin D. For patients that have very low levels, you'll be on higher doses than that, but regular supplements are either 400 or 800. And you'll see on a lot of the over-the-counter calcium supplements, so for women in particular that are post-menopausal and are told to take a calcium supplement, many of those have a vitamin D combined with the calcium. And again, that's just because of how important vitamin D and calcium are when they're trying, as far as how the body metabolizes calcium. I think I answered all of that.
Thank you very much. You mentioned that statins are not used in dialysis patients. Can you just explain why that is?
Yeah, and so I am not a nephrologist, so I'm not up on all the research on that, but I do know there is a higher risk of mortality for patients who are on dialysis who are also on statins, because we used to think you should do that, and we now know not to. As far as the mechanism behind that, I wouldn't be able to speak to that.
Okay. Well, as you're in primary care, when you see a patient that has chronic kidney disease, when should he or she be referred to a specialist? At what point should that person go to see a nephrologist?
Yeah, so that's a good question. It's a bit subjective, and it depends on the primary care physician. It depends on what else is going on. I think, for patients that develop kind of kidney disease at a young age, or out of the blue, or subsequent to some weird, again, to a toxin or to an infection or something, that you'd want to refer them to a nephrologist much earlier, like right away, because it's not, like a 20-year-old or certainly a child, ordinarily wouldn't develop the common causes of kidney disease, right? So if you have high blood pressure, heart disease, diabetes, and you're starting as a primary care physician, you're starting to note, you're getting regular blood work, once a year on these patients, and you're noticing that the kidney function is slowly starting to decline, then there's things that we can all do as primary care physicians. Again, it's really controlling the diabetes and high blood pressure. There's some dietary changes that can help, not so much for weight loss, but just for controlling sodium and protein levels. And then there's a certain class of medications which can help slow down the development of kidney disease. And so you'll do that as a primary care physician. If it continues to progress, and it's beyond the scope of this webinar to talk about how we stage kidney disease, but as you're getting into sort of that stage 2 or 3, so you're seeing the kidney disease is still progressing despite the appropriate diet, despite being on medication, despite having your blood pressure and diabetes controlled, then at that point it's important to get in to see a nephrologist.
Thank you. Listener asks, considering the new research that has shown that proton pump inhibitors can affect the kidneys, what should people do if they are prescribed these types of medicines by their doctors?
Yeah, so so I'm aware that there's studies that are showing a link there, and it's again, I think it depends on why you're on a proton pump inhibitor. So for those of you that don't know, those are fairly strong acid blocking medications for stomach acid, for stomach ulcers. There are now, many of them are over the counter, so like the Prilosec, right? Not the Pepsids, but the Prilosec and a couple of these other ones, the Nexiums. And there's been an association where they may be related to kidney disease. I think the important thing, what I try to do, at least in my practice, and this isn't just with proton pump inhibitors, it's with any medication, you want to make sure that there's a need to be on that. And if there's not a need to be on it, you shouldn't be on it, right? So many people get put on, or will start taking themselves, because it's now over the counter, a proton pump inhibitor because they've got some indigestion, or they had a little bit of a, they've had bad indigestion, they saw a GI, a stomach doctor, they did an endoscopy, put a scope down your stomach, said, oh, you got a little bit of gastritis, start taking this medication. And then they just forget it, they just take it, right? And they take it day after day, week after week, month, whether they need it or not, right? And that's what you want to absolutely avoid. But if you have a clear indication to be on it, the benefit certainly outweighs the risk. In general, with medications, again, if there's not a clear indication to be on the medication, you don't want to be on anything. You do not want to take even aspirin, right? So some people, or even doctors, will say, oh, we know that a baby aspirin a day seems harmless. It can help prevent heart attack. So even if you're a completely healthy, 50-year-old marathon runner, what the heck, just take a baby aspirin a day. Well, in that case, the risk actually outweighs the benefit, because the chance of that person ever having heart disease or stroke is incredibly small, but there is some risk associated with every medication, even a baby aspirin, right? So you just have to be smart about that and talk about that with your doctor and make sure that there's a need to be on the medication in the first place.
Thank you very much. I think we have time for one last question. A listener asks, what should you do if you have high cholesterol but can't tolerate statins?
Yeah, so again, I think it's, there's a bunch of different statins out there now, and some people that can't tolerate one can tolerate another. The most common intolerance of statins is muscle cramps, and quite frankly, most people, if you stay on it, those go away. And I'd say it's, in my own practice, I think it's maybe 5 or 10% of people have a little bit of muscle cramping. And it's, by and large, it's not a dangerous side effect. Now, when statins first came out, there was a concern about risk of muscle deterioration, when the muscle can really break down and it can be severe. And there was also a concern about a risk of liver disease and liver failure. So we used to actually test people's liver enzymes on a regular basis. But we know now that those side effects, those severe side effects, are incredibly rare. There's so many millions of people that have been on these drugs for so long. We know that those risks are really, really rare. The intolerance of the muscle aching is a real thing. It is, again, relatively common. Even if it's only 5% of people, when you think of the number of people that are prescribed these medications, it's relatively common. So again, make sure that it's a true intolerance and you can't take them. If it is, trying a different medication within that class. If you're on Lipitor, maybe try Crestor, maybe try another one. Some people will tolerate one over another. Some people will tolerate a lower dose rather than a higher dose. There's some homeopathic medications out there that may or may not have a little bit of a benefit. Again, optimizing your diet is key. And then for those, there's some people that have, truly elevated, high cholesterol levels, really can't tolerate it. There's a new class of medications out. It's an injectable medication, relatively new within the last couple of years, that's incredibly powerful, but incredibly expensive. I mean, to the tune of I think it's like $50,000 or $60,000 a year for these medications. So you have to have an absolute true indication to have to take that. But but for certain people, they can be life-saving. So.
Great. Thank you so much, Dr. Poffenroth, for the webinar and for sticking around to answer these questions. We really appreciate it.
My pleasure. All right. Thank you, Mike, and thanks for everybody for taking some time to listen in.
You're welcome.
All right. Bye-bye.
Our next webinar will be held on Tuesday, March 28th from 1 to 2 p.m. In recognition of National Kidney Month, this webinar will be hosted by a person who understands kidney disease on a personal level. Our speaker, Eric Dolby Sr., was a longtime dialysis patient and received a kidney transplant last year. Eric is a recipient of AKF's Hero of Hope Award and has acted as a patient advocate. During the webinar, Eric will discuss the meaning of being your own advocate in the healthcare setting and specific ways you can advocate for yourself as a dialysis or transplant patient. Registration is now open. Visit kidneyfund.org/webinars for more information and to register. When today's webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best it can be. From everyone here at AKF, thank you for joining us today.